Okay, if you can be seated, please. I hate to confess, but we are 5 minutes over, so let's start with Robert Adams. We've got five. I know. We've got the remaining five research ideas now, and then Dorothy's going to pull it all together. You're going to do the evaluation forms, and then we're going to be rewarded with networking drinks. So please welcome Robert Adams, Optimising Transformation, the application of simulation to transforming health, mental health as a case study. Ta-da.
Thank you. What I, on behalf of a group of us listed there from various places, are going to talk about today is the idea of adding sophisticated mathematical simulation modelling to some of the other ideas that we've really been talking about today around systems thinking and design thinking, operations research, in order to improve our understanding of some of the choices we have in making changes to the healthcare system before we make them, as well as during and after making them. Because the system, as we recognised, is not simple. That is a diagram of the interconnections of one service at one hospital to the various other bits of the hospital and other bits of the healthcare system that connect. And it is intuitively relatively easy to see from that any solutions to try and make changes or improve that, which may be glaringly obvious and clear and simple to one person at one point, may indeed be wrong. So one of the things you can start to do to try and unravel or try and understand that better is to create this sort of a model, which is that diagram written down with pretty colours and different lines. But it starts to map this process in a more orderly manner. And the more data you have around that process, you can begin to understand how bits of it may change. And you can begin to understand that if you start making changes down the bottom in the turquoise section, which is labelled discharge for those of you with 6.3 vision, might have an effect on the pretty light blue bit up the top, which is labelled ED boarding for those of you with the same 6.3 vision. And that the effects of any bit through that system during it will have an effect on other bits in ways that may not be immediately predictable. Because I think it's important to recognise the difference between what we would call a complicated system, which is like a rocket ship or a motor car, which is very complicated, but when you do certain things to it, 99% of the time you can predict what's going to happen. In a complex system like this, much of it is non-linear, so that if you make small changes in certain bits, this is the butterfly beating its wings thing that causes, the Amazon rainforest to fall down, you have problems. So what you can start to do with this is you can what-if questions to ask and then explore potential changes or questions before you actually make a very expensive, potentially mistake. Can you do this in the real world? Yes, you can. A group in the UK called the Cumberland Initiative, who have a lot more money than we do, have done a number of things, one of which was they were asked to look at optimising stroke care, and we know in stroke care, as John has mentioned early on, one of the things that's very important is to get the treatment in quickly, so to minimise time to treatment in order to optimise patient outcomes. Similar argument applies to cardiology and other sorts of areas. And they looked at various models and worked through with various people, and one of the things they came up with was the notion of having stroke patients and ambulances bypass the emergency and the stroke unit is activated in the ambulance and they rush up and start care immediately the patient arrives at the door. And that for those people who walk in through the door, they are triaged immediately to the stroke unit and bypass the emergency department. This was modelled beforehand. It seemed like it was a good idea, and so it was enacted down in Devon and Exeter, which is a relatively sort of diffuse area without a huge amount of population in a small area like say London. And they found out they could treat 4 times as many stroke patients in half the time, which was a fabulous success. Now the question you might ask, isn't this glaringly obvious? Why wouldn't you do it anyway? And surely we should just get on with it rather than mucking about. The trouble is that many obvious improvements, particularly to those people embedded in that sort of, spaghetti junction diagram, is that they're not necessarily terribly obvious, and reasonable people can have very conflicting views as to what a change might be unless they've actually seen it beforehand, or unless they can be shown it beforehand. As we were discussing at coffee before, reasonable people can barrack for Collingwood, for instance. So sometimes you need to convince people to change their practice, and modelling helps people do that because they get an idea about, you translate what is a good clinical idea into a process that people can see. And so the improvements predicted by the model convince the clinicians that it might be worth making the effort to change, and when it worked, that convinced them to influence the changes and go further from there. It of course has implications as well for the push to centralise stroke services, similar to some of the notions being promoted here in South Australia, which creates a tension between pre-hospital travelling times, ambulances driving past open emergency departments to get to a centralised place where there is a centralised specialised stroke service open that has better in-hospital processes. And you can begin to understand the trade-offs you're making there by the modelling, because you've got to put in things like the traffic and the time and the call to the ambulance against how well you're going to do it when people get there. Can we do this in Australia? To quote Bob the Builder, yes we can. The group of people, including clinicians such as myself, people who work in administration, public health, and very experienced mathematical modellers and operations research people came together last year, named ourselves after the Cumberland Group in the UK, with whom we have reasonably good connections, to try and introduce the notion of adding sort of modelling and simulation modelling to things like systems redesign and operations research. For a number of reasons, but one of which, at least, as I mentioned, is the means of communicating and discussing proposed changes with stakeholder groups. If 70% of changes don't work, and the main reason they don't work is the fact that organisations don't like changing and the people within them, one of the means of doing that is to actually present to people what will probably happen, or at least transparently you can see what might happen before you do it. And you can reduce some of the risks, because you can potentially test a lot more ideas and discard them using some reasonable assumptions and some reasonable data. And what am I doing here? I've got to here. So why might this be useful in mental health? The graph at the top there looks at people who get discharged from hospital from boarding. What we know is that some people get to hospital, get managed in hospital, and get discharged from hospital without ever actually making it into a hospital bed. This is somewhat distressing because corridors and ED cubicles are not ideal ways to spend days, and it's suboptimal from the terms of the treatment that they get. Now, what we know is that perhaps counterintuitively, the people who are discharged from boarding actually spend more time boarding than people who get discharged from somewhere else. So the people who spend a lot of time in boarding are spending a lot of time there before they get kicked out. It's not as if they're spending a lot of time there then getting into a bed. 6% of all patients get discharged from boarding, which isn't a huge amount, but if you consider if you could get rid of that, you'd suddenly have 5 or 6% increased capacity in your emergency department, which would be nice, I suspect, in the middle of winter. We know, however, that only 3% of patients admitted to a hospital for mental health conditions, but nearly half of them, 43% of them, get discharged from boarding. So that we have a large proportion of our mental health patients spend their entire hospital stay in a corridor in the ED cubicle and can spend days doing this. Now, there's a number of ways that might be effective, and there's a number of means you could think about how you might want to improve that, which comes to the sort of the graph down the bottom, which kind of looks through in a sort of very simplistic way a mental health process. People come to emergencies and then they spend time doing other things. They get into intensive care beds if they're really sick. They get admitted to acute beds. They run through other variations of subacute care, and they get into community health teams or community mental health teams, take their care towards the end. One of the suggestions from certain groups obviously is to increase the number of acute care beds, because then you'd have more beds to put people in to deal with the fact that people are getting boarding. One of the other ways is to look at some of the other changes you can make through the system, including down the bottom there, increasing the capacity of your community healthcare teams. And what we're looking at doing in the near future and over the next period of time is kind of modelling through which of those sorts of solutions or mix of solutions might in fact help with patient care, might in fact help with things like spending the boarding times, and might in fact help with length of stays in acute care beds and other places. We don't know what the outcome's going to be, but we can at least play around with some of the ways of doing that before we sort of say what you really need to do is have 20 more acute care beds, or what you need to do is double the capacity of your community healthcare teams. You can also look at the costs related to that, because of course it costs different amounts to do various things, and you can throw that into the notion of what is your opportunity cost, to take up John's point about having discussions around what sort of things are worth spending the money on and what you want to do. So it helps create a sort of transparency to that process so people can actually input into that. And I'm pretty much finished. That's my last one. An example of what you can do and how this might look is we've got a video stuck on YouTube, and we can give you the reference for that to look at what happens if you start changing resources in the emergency departments or not changing resources, and what happens to lengths of stays and waits. Which might give you an idea around the sort of things that we're talking about in a visual sense. For those of you who can't understand my drivelling, that may be more helpful to you. Thank you.
Just to remind people that what will be happening with the list of abstracts that you've all received, after this meeting we'll be inviting all of the authors to update or change their abstract in lieu of the conversation here, and perhaps you could add that link. Any questions of Rob? Do you want to add anything more?
Give an extra speech. I suppose a couple of points. One is that clearly, to go back to John's example there, one of the things that you could sort of add to that process is perhaps to go through some of the things, that are being proposed, that are evaluating and looking at what might happen before you do them, to sort of add a pre-point onto some of the sorts of things there. Two, obviously, mental health care is but one area of the healthcare system that you can do this sort of thing in. It's good because it's a relatively closed circuit system in the sense that people move from emergency through acute care systems and then subacute and out. But any number of other areas of the system could be looked at in a similar sorts of way. One of the things that is potentially a problem, of course, is the quality of the data that we have. We've got lots of data in certain things, but we have relatively poor data to monitor processes. And once you start delving into bits of our system, it's surprising how poor our process data actually is. And we really don't have a great deal of... In areas that you think might be much better at it, intensive cares, for example, have remarkably little idea what happens on a day-to-day basis to a lot of their people. And they're good at it.
Okay, we have a question. Hang on. No, we're taping it actually, so if you can just hang on. Thank you.
Robert, hi, it's Michelle McKinnon, Director of Safety and Quality for SA Health. Within the modelling, have you actually looked at the preferences of the consumers and their families around the model of care?
We haven't. You can.
I think it would be an important scenario to
again,
include.
Based on what sort of data you've got to do with it. Certainly looking at costs, qualities and dailies are certain things you can add in to get that sort of outcome from it. Modelling preferences depends on having preferences to people, which depends on collecting that data. And again, I think, we'd be kidding ourselves if we thought we had a lot of data in most areas of the system on the preferences of consumers in any sort of systematic manner.
While Sarah's getting the mic for Carol, can I ask you a question and we'll share that mic? That's okay. Hello. Mental health is one condition, but what percentage of people with mental health also have other comorbidities, and how does that fit into this model?
Most mental health patients have some sort of physical comorbidity, and from other work that I've done in other areas, I will tell you that the reasons they are sicker and die earlier and report worse quality of life relate to their physical complications more than their mental health complications. And again, I can tell you that we're pretty poor at managing the physical complications of people with mental health problems, partly because we silo things and partly because each set of professionals who look after them think it's someone else's problem to a large extent. Again, you can add that to the model. There's no sort of limit to the complexity of the model that you choose to construct. All you need is the data to do it, and the recognition that the more things you add into it, the greater the variation may be. But again, you can tell that if you get really good at managing the physical complications, people's mental health often gets better as well.
Yeah, it's one person, isn't it?
Yeah.
Okay, Carol.
Just thinking about the mesh between modelling and evaluation, and wondering whether you do with your work look at how things happen in real life afterwards compared to your modelling, and then whether that can actually then inform, sort of future modelling or future changes to the system. Is that something you do?
Ideally, that's the way the process
Right.
would work.
Right.
You'd compare, you develop the model, say this is what we think should happen, X changes occur, you then see what happens and where they differ, and you can then look at where the shortfall or the differences may have occurred. Because again, if you've got the data to do it, you can look at each bit as you go along and say, the problem was that ambulances can't drive up Port Road quickly, or no, the telephones don't work, whatever. So yeah, in an ideal world, that works in a continuous cycle. There probably aren't terribly many examples of that happening in the real world as yet, but watch this space.
Perhaps with transforming.
Okay,
Where's
any
Dorothy?
final question? And please take Robert Adams. And our next speaker